In the name of God, hello everyone, I'm Dr. Zainali, and today I want to talk about a patient whose life we were able to save through proper and attentive history taking. Have you ever encountered a patient in the emergency department whose history was completely unclear? Have you ever had difficulty communicating with a patient? I had a patient who was a woman, approximately 40 years old, who suddenly collapsed during a wedding ceremony. She experienced a sudden drop and lost consciousness, falling to the ground. When we examined her, she had low blood pressure, about 95/70, as far as I remember. She was also tachycardic, with a heart rate around 113. In addition to the syncopal episode, she was complaining of hypogastric abdominal pain. During history taking, she also mentioned rectal bleeding. Honestly, given her abdominal pain and hypotension, I initially felt that the rectal bleeding might not be the most significant finding. The first diagnosis I considered was ectopic pregnancy, especially since the patient was still tachycardic. I requested an ultrasound. That day, our emergency department was extremely crowded, and I wasn't able to perform a fast exam myself initially. During the time it took for the radiology team to arrive and for the patient to be taken for ultrasound, she suddenly developed a severe drop in blood pressure. Her pulse became barely palpable, she lost consciousness again, and her conjunctiva became pale. I immediately went to her bedside. I performed a fast ultrasound right there and found free fluid in the abdomen and in Morrison's pouch. This time, with the diagnosis of a ruptured ectopic pregnancy, I urgently transferred the patient to the operating room for gynecologic surgery. The patient underwent a successful operation. As you know, ruptured ectopic pregnancy carries a very high mortality rate. In this patient, if we had not paid close attention to the combination of abdominal pain and hypotension during history taking, she would have lost her life. These kinds of clinical subtleties come from careful observation and mindful patient evaluation. This means that when you see a patient with abdominal pain, you should not assume that it is the same as every other abdominal pain you have encountered. For example, even if a textbook lists 20 differential diagnoses for abdominal pain, your patient might fit the 19th one. That is why we must take histories intelligently and examine patients thoughtfully. What about you? Have you encountered similar situations? Have you had patients like this? I'd really like to hear your thoughts and experiences.